Hello again. In part 5, we're going to talk a little bit about the management of these precursor lesions. Once you have a little bit of an understanding of the clinical presentation of them and of their natural history, we need to have some understanding about what you might do with them. And there are various ways of looking at this, in particular how you might approach this from a primary care perspective, but also then what you might do with them once they are into the secondary care environment. This schematic outlines a number of the principles whereby we go about assessing and then coming to a management strategy for patients who have these potentially malignant disorders. The key part is the very first part. The key part is a clear, systematic examination of the oral mucosa. Obviously, before that, you will have your clinical history, but a careful, thorough examination of the oral mucosa is the most important part of this. You may then use screening tools. I'm going to talk a little bit about what screening tools are available. Many of them are not really routinely available within a primary care setting, although depending on the practice that you work in, you might find that some of them are available. With or without screening tools, the systematic examination along with the history and so on will allow you to come to a provisional clinical diagnosis. And if there is a lesion which is there, which is unexplained, but has been there for some time, then it needs to be biopsied so that a diagnosis can be made, an assessment be made of the need for any further management or treatment for the patient. So these two principles of careful systematic examination of the oral mucosa and biopsy are the mainstays of the initial part of assessment of these lesions. Obviously then, what happens after the biopsy is dependent upon the biopsy findings. If it is a definable lesion, for example, if that white patch is lichen planus, well, then you can manage it as lichen planus. If there is no definable lesion, but perhaps there is a suggestion of a cause, let's say that the white patch is more thought to be traumatic in origin, you could eliminate the cause and see if that then deals with the problem. No obvious cause brings us at that point into the whole ballpark of leukoplakia and erythroplakia, those of which there is no definable cause, and you're not really allowed to have anything else associated with it other than tobacco. If you eliminate the cause in the lesion where you do have a possible cause, get a good response, well then that essentially means you have defined the lesion in terms of the cause of that, and you can manage that accordingly. If you eliminate potential causes and you still get no response, or there is no obvious cause that you can tell from the biopsy, well then the main point of assessment that you're looking for is there dysplasia in this? Is there present in the histological appearance that which is going to give you a suspicion that there's an increased risk of progression to oral cancer? And from that point on, then management plans can be made, and we're going to talk a little bit more about that at the end of this section. So what about the techniques? Well, as I indicated, whilst I'm going to talk a little bit about adjuncts and various other techniques that are possible, the top part of a thorough and systematic examination of the oral mucosa still stands as the most single useful thing you can do. Some of the techniques are based upon staining the mucosa, toluidine blue for example. There are other systems such as imaging systems like Velscope I'm going to talk about. There are other ways of sampling the mucosa, like brush biopsy, which we'll come to, and then more sophisticated techniques building in elements of the biology of these lesions that are still in their development. So here is Oroscreen. Oroscreen essentially appeared on the scene when I was a student. And it is a blue stain for the oral mucosa. It is based on toluidine blue, and that is a stain which actually stains nucleic acids. And so when you have a lesion which has more cells, more DNA content, well then when you use this stain, it's going to stain blue. And you can see from the picture here that there's a lesion in the floor of the mouth with that blue stain that you can see. One of the main issues with toluidine blue, of course, is that there are many other reasons why you might have more cells and more DNA within an oral mucosal lesion. For example, in lichen planus, there are lots of lymphocytes there, they stain, and so the main problem with a stain of the oral mucosa was that it was not particularly sensitive or specific. Other mechanisms works slightly differently. And this device, which is known as Velscope, works in the principle of the autofluorescence of oral mucosa. If you shine a blue excitation light on oral mucosa and it's normal, it will emit a kind of apple green autofluorescence. And so you can then address the areas which are relatively normal. But where there is an abnormality, for example, in dysplasia, you lose that autofluorescence. And so it can be used to target areas which are more abnormal, which may not be absolutely obvious to the naked eye. Again, whilst useful in some contexts, the sensitivity and specificity of this kind of assessment has been drawn into question in a number of reviews of its efficacy. And so, for example, there are papers like this, which has come largely from the group at King's. Salmon Walnut in oral medicine and pathology has done a lot of work on these type of lesions. And this is a systematic review, and the conclusion of that is there is limited evidence for their use. That's these optical oral cancer devices in primary care. And these tools are better suited to specialist clinics where there's a higher prevalence of disease, and experienced clinicians may better discriminate between benign and malignant lesions. And so it really has to be used in the right context. But I do know that there are some private or dentists who do have a Velscope with it and kind of use that within their patient population. Something which is slightly different, which we're working on at the moment, and in fact we have a significant amount of funding for, is a collaborative project with a medical technology company called Zillico. And they have developed a device, which you can see in the bottom left here, which is currently part of the cervical cancer assessment process in the colposcopy clinics in Sheffield and in another number of other hospitals in the UK. It works on the basis of electrical impedance spectroscopy. That means it's passing a small electrical current through the tissue, and the resulting spectra that you get back as a reading from that allows you to then assess the mucosa and whether it's dysplastic or whether it's cancer or not. Many, many years ago, we used a prototype of this to assess oral mucosa, and we found that it looked as if it had some promise, and we have been working with Zillico over the past 2 years to develop an oral version of this. And this you can see on the right-hand side of the picture. And we are just in the process of working through some user tests with that and to assess a prototype. So that is a project which is ongoing, and we hope might come through to a device that will be useful in the assessment of the oral mucosa, probably at least initially in addition to biopsy, but might eventually reduce the number of biopsies which need to be taken. Another way of sampling the mucosa so you get a tissue sample to look at is what is called brush biopsy. Now this uses, as you can see, a rather interesting looking brush. I'm not sure I would necessarily like that to be used in my oral mucosa, but this brush is rotated, so there's a sample of the cells which are taken from the oral mucosa. It has to be relatively traumatic because you're wanting to get to the cells towards the basal compartment, which are in many ways the most interesting ones. And so brush biopsy means that you take a sample of the cells. You don't, as in a biopsy, get the relationship of the cells to each other, but you get a disrupted lot of cells that can be looked at. And so the cytological features of malignancy can be assessed in a smear. There was a company which was set up a number of years ago called Oral CDX who provided this as a service, and in fact there are a number of pathologists both in the private sector and also in the public sector who would provide this sort of cytological assessment of a brush biopsy specimen. In the UK, it's not really taken off. We tend just to say, well, the patient's going to have a traumatic incident, I'm going to have a biopsy anyway, so why not just take the biopsy in the first case and get the overall impression of the tissue in its right context, and that is largely what we do, but it is available should you wish to do it. Of course, when you take a sample of disrupted cells, it is possible to do other things with it. And so, again, in Sheffield, we have been working with Martin Thornhill, who's now the retired professor of oral medicine, at trying to take the cells from a brush biopsy, but look at some of the biological characteristics. What proteins do they express? What are the characteristics of the individual size and shape of cells and so on? And what do they tell us about the risk of progression to oral cancer? And there's a large 3-center study which is completed and is now, the work's been published from that, but we're looking hopefully to take this forward into more real-life clinical assessment of how this might allow us to predict the progression of these lesions. So that is something which, again, is ongoing. That having been said, the screening tools and all of these fancy techniques, the mainstay of coming to a diagnosis is still a good incisional biopsy. And you can see in the picture here what we tend to mean by that. It's got to be a good size. It's also got to be of decent depth. You've got to get right through the mucosa and into the underlying connective tissue, particularly if there's a suspicion that this might be a cancer. You really need to get a good depth of biopsy so that we can assess whether there is invasion into underlying tissue. The area selected here is across the edge of the lesion, so we do get a little bit of normal mucosa. And there's also the selection of an area of the reddest area, which is perhaps the most concerning. So back to our management scheme. Once we've got the biopsy, we work through this in terms of working out whether it is something that's a definable cause or not, eliminating possible causes, and if there's no cause, we're into this area of leukoplakia, erythroplakia, and the presence of dysplasia becomes the defining feature which essentially determines what happens from here on. So this is an algorithm which has come from the head and neck group in Liverpool, which essentially gives you an idea of what might happen to the patients once they actually have their dysplasia diagnosis. And so you can see the routine at the top here from referral, assessment, biopsy, and so on. And so then you come to the point, some of them, unfortunately, at the time when the lesions are biopsied are already going to be malignant. So from the left-hand side over, you can see those which are malignant that are going to go into the head and neck cancer MDT. And then there's this separation between those who have moderate and severe epithelial dysplasia and those who have mild epithelial dysplasia. So if we deal with the mild epithelial dysplasia first, well then the mainstay of that is twofold. It is dealing with the risk factors and routine monitoring of these cases. If these patients can have interventions which will reduce the risk factors, they stop smoking, reduce their alcohol intake and so on, it may be that they need no further treatment, but they do need monitoring over a period of time. And in this case, you can see in oral medicine and OMFS in Liverpool, they're suggesting that that's for 5 years. And after that, if the risk has been managed and the patient has had no progression of the lesion, they can be discharged to primary care. If there are concerns with that on an ongoing basis, or for example, the patient has had a primary diagnosis of moderate or severe dysplasia, they then put these patients into a dysplasia clinic. Now this varies. Some of these may well be a separate specialist clinic, or it may be a component part of either an oral medicine or an OMFS clinic. And these patients have got an enhanced follow-up regime. Some of them have close monitoring, particularly with some of the moderate dysplasias. It's difficult to know exactly with the moderates whether you intervene or not, but they need close follow-up over long term. There is a low threshold for rebiopsying these conditions, which if there's any change that the patient notices or the clinicians notice, it's important to have good clinical records and photographs and so on to allow that. And in fact, at times, even if the patient does not have an invasive lesion, it's not cancer, they may still undergo removal of the lesion. And that is particularly the case for the severely dysplastic lesions. Now, that can be done with cold scale scalpel, as usual, or in some cases, it's done using a laser. And depending on the extent of the lesion, that will either be done under general anaesthetic or local anaesthetic. So we do from time to time through our biopsy service here in Sheffield get wide local excisions of lesions which are severely dysplastic because the clinicians feel that there is really a significant risk of the patient progressing to cancer. And if you want to have a look in more detail at that and the reasoning behind that as an algorithm, you can see that in the reference which is there below. And in Sheffield, the practice is not dissimilar to this.